Yes, good morning, Professor. Most welcome. I think you had small problem in the airport.
Yeah,
So
actually, yes, due to this PCR test, but we have solved the problem.
we are in
So I'm ready.
Thank you for joining us, and would like to give you the floor. I think you need to share the screen with us that we can able to.
Yes, nereden yapıyoruz arkadaşlar? Okay, thank you very much for your the kind invitation. Now I
Just for a small reminder, when you finish your presentation, please stay with us a little bit because there might be some question from the audience.
okay.
Thank you. Please, floor is
So I
yours.
have been informed that I will talk about the surgical treatment of the spinal deformities, which is my main interest actually in my life. First of all, this is my team, and actually the number of people is more. Our center, Live Hospital Spine Center, is the fully certified spine center of excellence by the AO Spine. We got this certificate for 3 years, and every 2 years it should be renewed. So we are trying to be updated both in practice, both in scientific updates. Now I will start first and what is scoliosis? The scoliosis is the three-dimensional deformity of the spine. This is important because most of the people requiring surgery is the age between 10 and 20. So this age, and mostly in females, and this the group is somehow more sensitive in the self-appearance. And if this deformity is progressive, later on, if the deformity is progressed, there may be some medical problems. So in selected cases, the case-by-case evaluation, in selected cases, we are trying to correct these deformities by surgery. This case is a 13 years old girl. In our the practice, these types of curves is somehow simple curves. Of course, from the patient point of view, there's no simple, they're getting surgery, but it's quite simple and flexible. The surgeries are done in the prone position. We are exposed to the spine. And as you see from the video, we are placing these pedicle screws. This is the gold standard method. In some selected cases in the younger ages, before adolescence, we have some temporary growth, the procedures, but these procedures, as shown in video, is the gold standard. We call it posterior instrumentation, correction, and fusion. We fuse, we place the pedicle screws, we are applying the force which is in reverse this deformity and correct the deformity and fix at that place. In contrary to the main thought in the people, those patients after surgery is not disabled, is not handicapped. They can live their life as the normal people. They can do sports, they can do daily activities, and those the implants are made of titanium and stay in place for several years. They have no side effects for the patients, and we are not doing any more future surgeries to remove them. They are some part of they become some part of the body. There are some correction maneuvers. It is more technical details, but here, as you see, we correct the deformity. We are doing some compression and distraction maneuvers, and intraoperatively, before we finish the surgery, we are checking the final job with the X-ray, and if we are satisfied in the correction, we are ending the surgery. This is some post-operative. As I said before, this is some kind of simple curves which is flexible and can be corrected easily. There are some case examples having this fusion. Of course, not all curves are so simple. They may be some neglected cases, or there are some intraspinal abnormalities, congenital problems. They can progress more. This is one example, case example of this kind of curves. Maybe you can see from the there are some putting, there are some cuts I will explain. This is another case example. You see, it is quite the severe curve. The patient, although she's 13 years old, the curve is progressed so much. Actually, we don't know the behavior of the curve in the patients. In some patients, the curves progress rapidly. In some even, they regress or they stay like this. So there's no consensus in our literature. What is the etiology? What's the? I don't know. There are some theories that they blame some genetical problems, but there is no scientific established the reason for scoliosis. The second thing that we don't know, besides etiology, we don't know the behavior of the curve. As I said before, the curve can progress rapidly, can stay. So there are some criteria, both in the cosmetic and clinical point of view. If the patients are fit in this criteria, they are the suitable candidate for the surgical correction. This patient is operative holofemoral traction patient. During the surgery, we are applying a gradual traction for the severe curves, and without any additional surgeries, we can get these results. Of course, if the curve is rigid, we have to do something to make the spine more flexible. Any surgical techniques in spine is risky and dangerous in terms of the spinal cord affection. We should not do anything in the spinal cord. And the second thing, as these patients are having these deformities yearly, gradually, the sudden correction of these curves somehow can get harm to the spinal cord, which cause a disaster. We call it paralysis, paraplegia. So we have to be careful. It needs experience, and we have to plan the preparative plan for each patient one by one. There are some osteotomy, we call it osteotomy. That means the removal of some part of the spine, rigid spine, deformity spine before correction. Those osteotomy types from the simplest to the more complex one. If the patient deformity is not so rigid, but is not flexible enough for spontaneous the correction, that we are removing some parts of bone from the posterior part of the spinal column, which is called Smith-Peterson osteotomy. It can give us 10 to 15 degrees of additional correction. For example, this case, 3-level Smith-Peterson osteotomy. The patient has both scoliosis and kyphosis. Kyphosis is a sagittal plane deformity. And with this quite simple osteotomy, we can get additional good correction. Also operative clinical. And these Smith-Peterson osteotomies, posterior osteotomies, can sometimes be used in revision cases to correct the deformity. This osteotomy is especially suitable in the sagittal plane problems. Now is another patient. This patient has neurofibromatosis. Although it is 10 years old, the curve level is severe enough, is more than 100 degrees. The CT images of preoperative planning. Some videos intraoperatively. The patient, this side, left side is head, and the right side is tail, and we are removing. We are removing this V-shaped osteotomy in the apical part of the deformity. In this patient, we did 3-level Smith-Peterson osteotomy. Then, with the help of osteotomy, which gives the flexibility. We are placing the rods. We bend the rods preparatively to our desired correction, and when we place the rods with the help of these pedicle screws and rods, the spine is adapting to the new position. And most of the patients in these severe deformities, in the video, we are removing at least 4 or 5 ribs to correct the cosmetic appearance, which is most significant in these patients, and most of the patients come out of this stuff. This is the result after operation, and the clinical picture. The result is quite satisfactory. The spine is balanced, the shoulders are level, the waistline is level, which is the main aim of the spinal. This is another patient, very interesting patients coming from Iraq, I think, as I remember. And this left side, left upper side, is a normal daily condition of the position of the spine. The patient is living like this. We call it lordoscoliosis. There is lordosis and scoliosis. It was a very challenging the operation because the body is shaped like this for several years, and we are trying to correct this at the 2 or 3 hours period. So it is somehow difficult for the patients, also for the surgical team. And at the end, after the surgery, after many years, the patient is standing erect. This is another osteotomy. They remove more part of the spinal column, which gives us more correction. As you can imagine, if the complexity of the spinal osteotomy is at the same time, the risk of the neurological problems is also increased. But at the same time, if you do more osteotomy, you will get more correction. So, those osteotomies are not alternatives of each other. According to the patient needs and the property level, you have to choose one and do one. This is one example of the revision surgery. PCO, pedicle subtraction osteotomy, was done at lumbar and thoracic level at the same. Another patient example, both scoliosis and kyphosis, both frontal plane problems at the same time, and at the level of T12 pedicle subtraction, it will get. Of course, those osteotomies can be done not only adolescent, but also degenerative scoliosis. Ages also can get benefit from this kind of osteotomy for the sagittal and coronal. Bone-to-bone resection, removing some parts of the bone in addition to the intervening the disc. Of course, this gives more correction, especially in the sagittal plane. But if you do this, then you can get also correction in the coronal plane. Especially this kind of osteotomies is beneficial in the ankylosing spondylitis, which is the patients, and these patients even cannot drink the water in this position. Osteotomy and fixation, enough sagittal alignment. The most complex one and the most challenging one is vertebral column resection. That means the removal of the all vertebra, even 4 vertebrae. Of course, without without disturbing the spinal cord inside. But of course, you will get more flexibility and you will get more correction. We have published our results. We have quite big series in the posterior vertebral column resection. Now I will put one case example here. The patient has 16 years old, very severe, the curve, and a very deformed such as the coronal balance from the AP and now the posterior vertebral column resection technique is the same from the starting. Again, we are doing exposure, we are placing the pedicle screws. Of course, these somehow more deformed and more rotated spines, it's not easy to place the pedicle screws in experience. And also these kind of patients, the surgery is more bloody than the simple case, as you can imagine. Now we are placing the pedicle screws. I can skip. And at the same time, we are trying to remove the facet joints more widely to add some gain in the flexibility. And after removing the pedicle screws at the level that we are planning to do posterior vertebral column resection, we are placing a temporal rod at the other side, and we are first doing a wide laminectomy. And with using high-speed drill, we are start to do the wide laminectomy, and after finishing the laminectomy, we have to remove the vertebral body. It depends on the preference of the surgery. You can start from the convex side or concave side. My preference is to start from the convex side. If we are in the thoracic region between T2 and T10, we easily can sacrifice the nerve roots there. Now I'm doing this in the video now. If we can sacrifice one or more nerve roots bilaterally, even in the thoracic spine, actually it gives nothing. So it in terms of harm to the patient, of course, but it gives more space for our working. There is no neural tissue in front of our eyes. So after sacrification, it's very easy actually to start to remove the vertebral body. Now we are doing this is the convex. So this is the convex side, and we are trying to remove the vertebral corpus from the convex side. Then high-speed drill is mandatory in this guide. Even in some cases, we are using some osteotomes, but high-speed drill burr, diamond tip burr is very important. With the fluoroscopy, we are checking our the levels. It should be on disc level in the both sides. With this approach, the up level is to remove 4 levels. Leaving the spinal cord. Then, after finishing the osteotomy, leaving the posterior cortex in the convex side, then you have to do the same thing on the concave side. And the osteotomies should meet in the middle. The happiest time in the surgery. It means when you meet from the 2 osteotomies in the middle, it means that you have only leave the posterior wall, which is very easy to remove. After you remove the posterior wall, actually there is no bony connection from the upper part. So with the carrying the spinal cord without any the sudden movements, gradually the easy. After removing all these bones, then again we are placing the rods we are trying to adjust the rods into the pedicle screws, and of course neuromonitorization is essential in this surgery. The neuromonitorization team should be in accordance with the anesthesia team. The patients should be taking the very tiny balance, but with the guidance of the neuromonitorization, we are trying to make a correction gradually. And at the same time, if neuromonitorization says you that the signals is decreasing, that's the time you have to stop this maneuver and you have to search for the alternative maneuvers. Some correction maneuvers, it's more technical, but you have to use any correction maneuvers without disturbing the spinal cord. If there's a gap between these two bones in the osteotomy site, we have to use these mesh cages. It's spacer, because if you try to approach these two bones together, there are some thinking of the spinal cord which can cause neurological. This is the postoperative X-ray. If you can look carefully, there's a mesh cage here for the spacer. And this is the end results, the clinical results. The appearance, cosmetic appearance is perfect. The patient. So the posterior vertebral column resection is the highest level in the spine. There's some patients examples having posterior vertebral column resection. Of course, as I said before, in the thoracic spine, it's very easy. In lumbar spine, you can do if needed. But most of these severe rigid deformities, the apical region, thoracic. Another patient, 20 years old, very complex congenital neglected scoliosis, and this is as I said before, we are quite experienced, and we are trying to publish our results. Another challenge in these patients in the severe deformities is the coincidence of the intramedullary abnormalities. Our approach is to solve all these problems at the same time. So with the neurosurgical team, first we are placing the pedicle screws, then the neurosurgical. Then we are doing osteotomy even at the same level or in a different level and do the correction. Of course, this kind of surgeries is a long-lasting surgeries. It needs a highly motivated team, not one-man show. It lasts at least all on the day of the surgery, but the results are. We have some facilities in our center to make these mistakes less in is the spinal robot, which help us to precise location of the implant. Those are some. This is the youngest the patient of mine. This is hemivertebra. This is another area. This is the congenital absence of the vertebra in one side and the addition. Kind of deformities progress more rapidly, so you have to do things as recommended age is around 2 or 3 years, but if the conditions are good, you can do even in the youngest age of 1.5. The removal of 2 vertebrae and the Yes, one more challenge. If you are doing deformity correction in the elderly, of course, the bone quality and osteoporosis is an issue. There's some the tricks. There's some different kinds of instruments that can be used. And the metals, pedicle screws should be the bone cement. There's some products which helps us. The sagittal plane deformity, kyphosis, is more commonly in the adolescent period in the boys, the scoliosis in the girls, and this type of kyphosis, called Sherman kyphosis. The the mechanism of thinking, the logic is the same, but the deformity plane is different. Before we are trying to evaluate the flexibility of deformity, and again with the help of pedicle, very powerful instrument. Pedicle screw placement and the making the correction maneuver in opposite direction to the deformity is the choice. And we have since, as I said before, we have a certified education center by AO Spine. We have some fellows, long-term, 6 months, 1 year fellow taking education. Yeah, we have a very informative and strict the program for them in terms of this and in terms of scientific education, and we are trying to export our scientific knowledge all over the world. We are the education center of several medical companies, and the doctors wherever can come and can practice these surgical products. Thank you very much. It's the
Professor Cagatay. There is 3 questions actually for you. I'm really thanking for this amazing, amazing presentation with amazing work, very comprehensive work and very detailed surgery, and detailed presentation was very educative and informative. The first question come from Russia, actually. Do you perform surgery for pectens excavatum surgery? They are asking.
Yeah, pectus excavatus is the job of the thoracic surgeon actually, but most of the patients having pectus excavatus has, although since it is connected with the spine, as kind of spinal problems. If one patient has a pectus excavatus, we are always make the small consult with the thoracic surgeons from which we have to start. Sometimes we are starting from the spine. If spinal deformity is not so huge, then we are moving the patients to the thoracic surgery department. Pectus excavatus is somehow cosmetic problem, but it's very important problem. Our thoracic surgeons can do the surgery successfully. I'm not doing personally this surgery actually.
Thank you. The second question, do you use any less invasive techniques like apifix when it is possible?
Yes, I know this technique, which was originated from the Israel. We applied one patient. In the laboratory, theoretically, this apifix system is working, but in the reality, in real life, it's not working. I'm not so happy with this technique. And the problem in the scoliosis is 3-dimensional, as I mentioned before, not in the right or left bending. At the same time, the vertebra rotates itself. This apifix system can somehow handle this right and left bending, but cannot do anything with this rotation. So most of the people, also the people using this system, is complaining about the implant problems in these patients. We have no chance to do several surgeries. We have to fix the problem and solve the problem in one surgery, and this surgery should be the last surgery of the patient. So I'm not using EPI.
Thank you. I think this question comes because Israel as a destination quite popular in the CIS region. So that's why they might receiving some offers that we are using this technique and this is the best and etc. Maybe that's why the question came. It was a question of medical travel agent actually from Russia. So thank you for the answer. The last question, from what age do you take a patient for scoliosis correction surgeries? Any limited on the...
Yes, yeah, actually I didn't mention in my presentation. That's why it's a good question. In the concern that we are doing scoliosis, the surgery, we are fixing the spine. It means we stop the growth.
Yeah.
According to the literature, the adolescent at the age of 13, 14, actually they have completed 95% of their spinal growth.
Right.
The tricks from the X-ray, that if the spine will grow anymore or will stop its growth. If the science says that the spinal growth is 95% is
completed,
we can do these surgeries safely. If not, for example, if the patient is the age of 7, 8, which is still has time to the growth, we at that time we have some techniques called growth-friendly surgeries. This is temporary surgeries.
mm-hmm.
We apply this surgery at depth of 7. Our aim is not to correct deformity totally. Our aim is to control the deformity at the same time allowing the spine to grow. We follow these patients. There are several techniques. We follow these patients till the age of 13, 14, and if we are convinced that it is stopped, then we jump to the definite
final operation.
Exactly.
Great job, Professor. Really, I'm proud what you are doing. I'm happy on behalf of the humanity and on behalf of Turkey as well. Really having you as star doctors in our in our country that help Turkish and international patient for this really deep and big problem on the comfort of life, because without having the right correct position, you cannot have the comfort life within the future period. Thank you very much.
Thank you very much.
For learning and contributing.
Good luck.
Thank you.